The war on HIV and other infectious diseases in developing countries can't be successfully waged by simply providing the appropriate drugs. What else is desperately needed, and who is providing it? Join us on Voices of Vision. In most developing countries, the fight against HIV, AIDS, and other infectious diseases has historically had more to do with patients dying than effectively treating them. While antiretroviral drugs, or ARVs, that reduce AIDS to a chronic disease rather than a deadly one have become readily available and much less expensive, they are of little use in the hands of healthcare workers who have little experience in the long-term management of HIV with ARVs. In 1990, some 8 million people globally were living with HIV. By 2005, that figure had jumped to more than 38 million. Africa and Asia account for nearly 33 million of these. Since 1981, more than 25 million people have died from AIDS. And in Africa alone, there are 12 million AIDS orphans. In the West, education, training, treatment protocols, and ARVs have been instrumental in controlling HIV/AIDS. However, developing countries, and particularly those with a lower rate of prevalence, often don't have the necessary experience to successfully treat HIV/AIDS, even if they do have access to the drugs. Initially, healthcare workers from these developing countries were brought to the West for training. It soon became clear that these local physicians were returning to their native countries knowing how to treat patients in the more sophisticated healthcare environments of the West. But what they learned had little application in the understaffed, under-equipped hospitals of home. Dr. Marie Charles has spent much of her medical career overseas and has a profound understanding of HIV and antiretroviral therapy. In November of 2001, she founded the International Center for Equal Healthcare Access, also called ICEHA, a fresh approach to training healthcare professionals in resource-poor countries. She was one of the first to recognize the key problem to this West-based training.
They are seeing then HIV care provided with the very best resources you possibly can get, the ones we have here in the West. And it's a very different scenario. So they are not necessarily able to pick up what are these specific details that they need to go back to their country and provide the best care possible within their existing resources.
As the head of a well-funded HIV research organization based in Amsterdam, but researching in Africa, Dr. Charles made a startling discovery as they arrived with their ARVs.
The nurses and the physicians present were very happy to see us. They were very curious about what those medications in our suitcases would do, but they didn't necessarily know how to diagnose an AIDS patient. They didn't know how to exactly use the medications. And this is in the late 90s.
Armed with this profound revelation, Dr. Charles took action.
What the program really did was prove the point that provided healthcare infrastructure exists at a very basic level, you can indeed provide antiretroviral medication to HIV-infected patients in a resource-poor setting.
The real dilemma, however, was how to achieve the same results on a worldwide scale, how to efficiently provide the required expertise.
You realize that there is such an untapped resource, almost unlimited resource in the West, and the resource is expertise. It's clinical expertise. All of us healthcare providers who know what to do with an HIV-infected patient know how to provide the best HIV care. This is a resource that currently, with all the funding we're spending for the HIV epidemic, nobody was really tapping into.
This insight put Dr. Charles on a radically different path than others in the field of HIV education.
It really was, the idea was, okay, we'll be a little peon almost, or a catalyst in the middle that brings two sides together. One side of great expertise and passion, people who want to make a contribution to the HIV epidemic as an individual. So they're looking for a very structured and managed opportunity to go to a developing country, hit the ground running, make an immediate impact that they can see, and come back to their own life here in the West.
Bill Drayton, Assistant Administrator of the Environmental Protection Agency under President Carter, is chairman of the Ashoka Foundation. He has been called the father of social entrepreneurship in the United States.
Social entrepreneurs are the people who change the system. We know that we're supposed to give people fish when they're hungry and then to teach them how to fish. Social entrepreneurs are the next step beyond that. They're the people who transform the structure, the design of the fishing industry.
He sees ICEHA as a nearly perfect example of social entrepreneurship.
What Marie and ICEHA have done is classic entrepreneurship. They have focused on where the system is stuck. They've imagined the most highly leveraged, most effective way of fixing that, and then they've been evolving very quickly over just a few years how to make this work at scale.
Sustainability is a cornerstone of the clinical mentoring system that is at the heart of ICEHA.
We want, yes, maximum return on investment, which means ultimately helping to curb an HIV epidemic in a country at a national level. Not just be effective or work in one clinic, but we want to have access or help all the clinics in one country. At the same time, we also don't want to recreate Western healthcare, because ultimately in the West we have a lot of resources and we deliver care in a very different way than can possibly be done in a developing country. So the only care that is sustainable in a developing country setting, sustainable forever, is HIV care that takes into account whatever resources are available in that country.
ICEHA provides Western healthcare professionals who transfer skills and knowledge directly to medical professionals in low-income countries in their own clinics, rather than providing medical volunteers who would take care of patients directly, as many other international development agencies do.
Usually we send teams, which is one doctor and one nurse go together. They stay for 6 to 12 weeks, they come back, and we send a new team to the same clinic. And it isn't, the reason why consecutive teams are necessary is because you're actually changing attitudes and you're influencing or changing systems, helping them be set up. And 6 weeks is simply not enough for a system to be set up and remain in place.
Mentors are sent on a by-invitation only basis, and the host country is responsible for very specific preparations.
All the other pieces necessary to curbing the HIV epidemic do actually need to be put in place. And the other pieces include prevention programs need to be put in place, strong political commitment by the governments, drug supplies, medications for HIV need to be put in place, need to be in place. The local physicians and healthcare workers need to have had some kind of form of basic HIV training.
A physician for more than 20 years, Dr. Stephen Klotz is now an instructor at the University of Arizona Medical School.
I wanted to do something a little different than what I had been doing, and perhaps a little more for HIV. In my current job position, I'm in charge of a government clinic that we take care of, the primary care of patients with HIV/AIDS. But it felt like I wanted to do a little more.
Dr. Klotz will soon be on his second ICEHA mentoring tour, this time to Ethiopia. His first trip took him to Vietnam, where he found healthcare professionals eager to learn.
Shortly after arrival, within a day, I was at a clinic that had just been opened by both ICEHA in conjunction with another organization and the government of Vietnam to help mentor their physicians on HIV care. They had 3 physicians, none of whom and furthermore, that applied to all the staff in the clinic, had, as best I know, seen what they knew to be an HIV patient. Yet they had volunteered and attended a theory course of how to manage and diagnose different diseases associated with AIDS. And shortly after that, the clinic opened and I arrived, and we worked on a one-to-one basis, seeing patients together, having some sessions after the clinic was closed to go over some of the aspects of HIV/AIDS that they still had to learn. And it was a very intense experience.
He was, however, taken aback by the overall conditions at the clinic.
We had 3 exam rooms. They were really quite thin and narrow, and you could hardly turn around in them, and they had just enough room to put a bed. And there was no air conditioning, and of course the temperature in Saigon at that time when I was there was in the upper 90s every day, and the humidity that was well over 90. And our only ventilation was to open up all the windows.
Dr. Nguyen Ton Lim is the chief of Binh Ton Outpatient Clinic, Ho Chi Minh City, Vietnam.
It was a very rewarding experience, not only for myself, but ultimately for the patients. After working side by side with the ICEHA mentors in our own clinic, we were able to treat more patients efficiently and effectively. I think working together in the local clinics provides all involved a greater understanding of the hardships suffered by not only the patients, but the doctors and nurses as well. And the drugs they provided were a tremendous help in treating this horrible disease.
Dr. Richard Kaufman first heard about ICEHA through an email requesting volunteers while a member of the board of the American Academy of HIV Medicine. He went on to spend 12 weeks in Cambodia with ICEHA.
When I was growing up, my mother and my dad always envisioned me as becoming a medical missionary. That didn't happen. But when I saw that email, I said, boy, this is my chance.
It was a life-changing experience.
HIV and AIDS has totally decimated the population. Men, women, and children are dying by the scores every day. Touring the hospital wards, the bodies that are lying on their mats, no mattresses, just mats, emaciated, it's pitiful. It was totally opening my mind to what's going on out in the rest of the world. I'm now truly convinced that here in the United States or in the Western world, we truly do live in a bubble.
The need for clinical coaching is not limited to doctors. Born and raised in Boston, Brian Fitzgerald has a 36-year nursing career. She was assigned to Cambodia as well.
I had never been to Asia. It was quite a cultural change. I partnered with a physician, and our assignment was to respond to the needs of the Ministry of Health and to educate the nurses and the physicians to prepare for the arrival of the antiretrovirals.
Nurse Fitzgerald's experiences in the U.S. and other countries where she has worked didn't compare to what she found in Cambodia.
The hospital was like nothing I had ever certainly seen in the United States, and I have worked in other developing countries. It was like nothing I had ever seen anywhere. It was about 12 beds. It was open air, no running water most of the time. Some of the time there was a spigot which had running water. 2 nurses on duty, 24 hours a day.
Not one of the 6 nurses at the clinic spoke English. But not only was language often a challenge, but ensuring that changes in health worker behavior were consistent with local guidelines and resources.
The learning experience was, it was vibrant, it was different than anything I had ever experienced, and it turned out by working with and doing with rather than sitting in a classroom, that it worked best for the nurses there.
The change was palpable.
And in the beginning, I must say that they were too busy to spend time or to do anything. And over time, I found that they became more involved, they participated more. Something else that happened was they became more animated. They would be more social, they would laugh more.
On a recent visit, the success Dr. Charles found at Binh Thanh Clinic in Vietnam represents the power of the clinical mentor model.
When we sent the first team of clinical mentors, there were no patients here in HIV care at all. After the first clinical mentor actually completed his 6 weeks, there were 200 patients in HIV care. After the second clinical mentor, 6 weeks later, after the second clinical mentoring team completed their assignment, there were 600 patients in HIV care, with more than 1,000 patient visits a month. Another 3 months later, and 2 teams further down the road, there were 1,200 patients in HIV care. And by now, we have in this clinic 1,500 patients, about 1,500, who are in HIV care when none existed before, not even 1 year ago. And the most beautiful thing of it all is that this care is actually being provided by the local healthcare workers.
Each mentoring team member is a volunteer who's been carefully screened and trained prior to being assigned.
We couldn't do anything that we do at all if we didn't have these volunteers, if we didn't have this human capital, really. So what we do is we want to get as much information out there as possible about not just about ICEHA, but about the opportunities that are available for healthcare providers. So in terms of recruiting people, we do things like we speak at clinics around the country, we speak at hospitals around the world, we go to a bunch of HIV conferences and courses and seminars to let healthcare providers know. And then these days, what's really exciting is that as people come back from assignments in the field, as volunteers come back, they're telling their colleagues and their friends about the assignment. And it's really that word of mouth that is getting people really excited about the organization and bringing a lot more people in.
Katie Graves, AB, has a master's degree in international affairs from Columbia University. She manages the volunteer recruitment process.
Once someone comes to us and indicates that they're interested in a volunteer assignment with us, we'll have them fill out an application, and then also submit references, do a background check on them. But the key portion is really that we require all potential volunteers to go through a training workshop with us here at ICEHA. And the purpose of that workshop isn't just so that they can learn about the organization and the clinical mentoring model, but so that we can also meet every potential volunteer face to face and interact with them and see if they really would be a good match for the organization and the clinical mentoring model or not.
An AIDS-certified RN, Robin Bohannon is from a rural area of Pennsylvania and has spent more than 20 years in nursing. She spent 2 months mentoring in 2 clinics in rural Lesotho, an enclave nation of South Africa.
Developing trust is one of the biggest keys to mentoring, and ICEHA certainly discusses that in their preparation of you for the mentoring program. And just having that background of the rural culture and being able to talk to people and feel familiar with them actually really helped to develop that trust between the caregivers there and myself.
Nurse Bohannon was kept busy while she was there.
Areas I worked in were Mahalishoek and Kuting clinics. In Mahalishoek, what I would do is I would work half of the week in one area, and then there was someone that would transport me to the other area. In Mahalishoek, they had ARVs, antiretroviral medications, for about 10 months before I got there. In Kuting, they had just received ARVs 2 weeks before I got there. During the time that I was there, we were able to get more than 40 people started on ARVs in the Kuting clinic.
Lesotho had established very clear guidelines regarding HIV treatment, but the local nurses didn't have access to those guidelines until Nurse Bohannon provided them.
What ended up happening in that was, as Melite and Ampo and the other nurses became more familiar with the guidelines and with the directions of what to do at what stage and how to dispense the medications, they began to take that initiative upon themselves. They started, when a person came with a certain weight, they would be on a certain level of medication. But as their weight increased, the guidelines clearly stated that you could increase that level of medication as was appropriate. And they would the nurses began to say, oh, well, he's over 40 kilos now, we can increase this to whatever.
The ICEHA model's ability to adapt to varying circumstances contributes to its continuing success. Dr. Stephen Mills is a representative of Family Health International, ICEHA's partner in Vietnam. He has witnessed the success of ICEHA's approach.
This clinic that we're in here has essentially graduated from the assistance that ICEHA has provided. And so mentors are now in other clinics that haven't benefited from this service. And BINTAC Clinic here is essentially working on their own.
Traditional training programs that rely heavily on the classroom experience have not been nearly as successful in establishing quality ARV programs.
It's very different to tell somebody, these are the steps you have to take to do spinal tap, as opposed to giving them the confidence to pick up the needle and stick it in somebody's spine, drain out the fluid and make the diagnosis. And it's not a big step, but it's a small little step, and coaching a healthcare worker a few times on how to do it so he is confident he actually can do it successfully and it's not scary anymore, totally makes a difference in the world.
Dr. William Hasseltine is the chairman of Hasseltine Global Health and a strong supporter of the ICEHA financial model.
First and foremost, it has almost no overhead. The funds that are used to support training, recruitment of volunteers. Once the volunteers, who are doctors, arrive in a country, the country itself pays the expenses. So for every dollar you give, there's about a $4 direct donation from the host country.
Dr. Hasseltine is convinced that not only is the financial model sound, but the clinical mentoring model is the best for achieving the goal of quality worldwide HIV treatment.
This is a sustainable model because what it basically does is transfer skills from one group of people to another. Once those skills are transferred, they're there, they're resident. And those people themselves can train others. It's a catalytic model. It's always better to invest in catalysis than in the substance. This is really an innovative, very effective model. I think it's probably the right model. Not only is it cost effective, it's the right model to have the maximum impact in a country.
To date, ICEHA's clinical mentors have delivered over 4,200 days of clinical mentoring to more than 580 healthcare workers in Vietnam, Cambodia, Fiji, Lesotho, Ethiopia, and Rwanda. As a result, tens of thousands of patients receive medical care when they had no care before.
We are already scaling up, and we have about 25 to 30 new applications a month now from across 10 different countries. We're scaling up in Europe as well. We'd like to get to at least 50 or 60 new applications per month, and ultimately start sending out about 500 people per year for 6 to 12 weeks to developing country. But also moving much beyond HIV epidemic, because if we really truly do our job, meaning empowering our local colleagues to provide the best care possible within their own setting, then ultimately we should be out of a job. And that's kind of where ICEHA should be going if we're only staying in the HIV field. But we're probably expanding into other infectious diseases.
The search for Western healthcare volunteers is ongoing, but it's made easier thanks to the experiences of the mentors who have already participated.
When they come back, it's like they have been given a second life. And within a couple of weeks of them coming back, every single one of them calls us up or sends us a letter or an email basically saying two things. One is, this was the most extraordinary experience of our professional and personal life ever. And the second thing they ask us is, when can we please go again? Or we'd like to go again.
The experience is one these adventurous and generous volunteers will treasure forever.
It's very rewarding. I think there's something about physicians asking you for help and sincerely wanting to learn and needing to learn to handle a catastrophe that's occurring that somehow is very rewarding. I don't know how to quite put it, but so there's a selfish aspect to this too, but it wasn't one that I had envisioned when I began.
That it was the most important thing I've ever done in my life, and I will forever treasure my experiences there.
I think most of us that have come away from our first experience want to go back. It's just making the time and the financial sacrifice. But it's an amazing, of all the places I've been in the world and of all, I do a lot of public speaking, there's nothing. I have never experienced anything like my experience with ICEHA, and it's been first class from top to bottom.
When I came home, the questions never stopped. They just continued to ask, well, what was it like this way, Mom? And we shared so much of the experience there together that one day we hope to, as a family, at least my husband and I, to go back to Africa and to work for a longer period of time.
Only with the sacrifice and commitment of caring healthcare professionals who have the privilege of quality education and the support of their workplace can a program like ICEHA support the control of infectious diseases like HIV/AIDS. The task is daunting, but certainly not unachievable.
The model is solidly proven, but even beyond all these very nice, I guess, business-like attributes of the model, it truly does come down to people and their passion. And in that way, ICEHA's success is the attest to the true human spirit.
For more information about Voices of Vision or the organization profile, visit our website at www.voicesofvision.org.